Good afternoon, everyone. Welcome to our Tuesday Multi-Modality Imaging Conference. Myself and Dr. Chebrolu will be presenting to you on how echo and CMR can be used in valvular stenoses. Please join us in this conversation. You can join by the web. Go to pollev.com, enter DeBakey and respond to the activity, or join by text. Text DeBakey to 37607. And you can leave a message and we'll be happy to answer any of your questions. So it gives me great privilege to begin today, and I'll introduce my friend and colleague, Dr. Bindu Chebrolu, who is an expert level 3 echocardiographer who will speak to us on mitral and aortic stenosis assessment with echocardiography.
Hi everyone, I hope you can hear me and you can see my slides, I think. A very good afternoon. Today we are going to talk about actually echocardiographic assessment of aortic and mitral stenosis. I'm going to try my best to keep it brief and focused so I give Dr. Nabi enough time. Sadly, I don't have any disclosures, and don't forget our favorite Twitter handles, and for our viewers on LiveStream, please subscribe and follow DeBakey Institute for Cardiovascular Education and Training for current updates in cardiovascular sciences. And a special thanks to Dr. Zagbi and Dr. Faisal for sharing some key slides. And sorry, I have to say this, please mute yourself if you're not speaking. And of course, we are going to base our discussion as directed by our guidelines, both the valvular stenosis guidelines from 2009 and the more recent updated guidelines in 2017 on aortic stenosis, which actually delves into specific details and challenges in the multimodality assessment of aortic stenosis. And let's see which one do the audience want to pick first. I think I hear mitral. All right, let's go into mitral stenosis. Some fun, interesting facts in history, right? So mitral stenosis was first described actually by Dr. Vucens in 1705, and who called it actually a bony transformation of the mitral valve. It was the first valve lesion treated in surgery in 1923, and the first ever valve disease diagnosed by echo in 1968. And it was actually the first ever valve lesion treated successfully with percutaneous balloon valvuloplasty in 1984. And seen here is actually a cute video of an exercise stress auscultation in the good olden days. Now let's talk about what do we know in 2020. So, sorry, being an echo and a Jeopardy enthusiast, I had to keep it, keep some questions at least. It's a rapid fire question series, so please jump in if there are any takers. Please unmute yourself and answer the question if you know that. So our first question, this syndrome of mitral stenosis associated with ASD is called? Any fellows, any takers? Well, I'll give the answer. It's Lutembacher syndrome, right? The next one. This finding caused by severely dilated left atrium, most commonly from severe mitral stenosis and sometimes associated with dilated pulmonary artery is called? Any takers? Well, this is Ortner syndrome, also called as cardiovocal hoarseness, and it's basically caused by recurrent laryngeal nerve paralysis. And finally, this pattern of cyanotic red and congested cheeks seen in severe mitral stenosis is called? It's called mitral physis. So moving on, here's an outline of what we are going to talk about mitral stenosis today. So we're going to briefly touch base about mitral valvular anatomy, the causes and anatomic presentation, the valve area and other indices of severity, and a little bit about grading and management of mitral stenosis. As we all know, mitral valve is typically 4 to 5 centimeters square in area, and we all know the components of mitral valve, which is basically the annulus, the anterior and posterior mitral leaflets, the chordae tendineae, and remember the left atrial wall and the left ventricular myocardium are also part of the mitral valvular apparatus. It's very essential to remember that knowing and understanding the anatomy plays a key role in the assessment of mitral stenosis. And again, these are some basic transthoracic views, which we all know, and this is a normal MO tracing of the mitral valve, showing the early filling and the atrial filling waveforms. Again, TE is the preferred assessment for detailed assessment in case, if we need to really rule out left atrial appendage thrombus, or also in cases where the transthoracic is suboptimal quality. And again, 3D provides incremental data about valve morphology and anatomy. What are some of the common causes, right? So let's start with our famous or classic rheumatic mitral valve disease, mainly characterized by commissural fusion, as you see here, and also caudal shortening associated with leaflet and subvalvular thickening and calcification. The classic echo feature, as you see here, is that classic hockey stick appearance of the anterior mitral leaflet. The M-mode findings are also diagnostic. Again, you see thickened leaflets with commissural fusion, decreased E to F slope, and also you see the parallel motion of both the leaflets, which is mainly because of the consistent pressure gradient throughout the diastole. And then we have our degenerative causes, right? Typical ones being the calcified mitral apparatus causing restricted mobility and poor cooptation, as you see here, and can result in mixed valvular disease with both stenosis and regurgitation. It's usually seen in the elderly patients and also associated with hypertension, prior chest wall irradiation, CKD, atherosclerotic disease, and aortic stenosis, and it is usually difficult to treat. And then we have our inflammatory conditions, right? So some examples here are actually the carcinoid valve disease. You see the thickened and tethered leaflets, which can usually result in mixed disease. And it's actually characterized by endocardial plaques or fibrous tissue involving both the leaflets and the subvalvular apparatus. And left-sided involvement is actually seen in 5 to 10% of cases and usually should be suspected with extensive lever mets or bronchial carcinoid or in the presence of an intracardiac shunt. And this one here is actually an example of a radiation valvulitis, which again, you see there is on 3D, you see the calcification of the anterior mitral leaflet in addition to calcification of the aortomitral curtain. And then we have our vast majority of congenital cohorts, right? You have multiple variants, including the supravalvular variant of fibrous ring, Schoen's complex, the valvular variants where you see sometimes double orifice mitral valve and hypoplastic valves, and also the subvalvular variants like parachute valve, where you see here actually the whole mitral valve is connected to a single papillary muscle. And also there is a variant called hammock valve or anatomic or anomalous mitral arcade. And evaluation of mitral stenosis in a methodical way is very important, right? It's actually typically starts with analyzing the valvular anatomy and looking at what are the various indices of severity, and also looking at associated lesions and some modifiers in some special situations where a multimodality approach might be needed. A thorough 2D assessment is a key component, and in addition to looking at the valvular and subvalvular anatomy, bottom line is look at the big picture, right? And look at the whole picture in addition to clinical assessment. So starting with our valve anatomy, so very important, right? Because it has implications in the choice of intervention. Most important components being assessment of commissural fusion, subvalvular thickening, as you see here, and also the degree of calcification. And there are various echocardiographic scores which have been used mainly to assess pliability or splittability of the valve. We know this one, the classic or famous Wilkins score, where we gave a score of 0 to 16 based on mobility, thickening, caudal involvement, and calcification. And the score ranges from 0 to 16 with a score of less than 8 used as a cutoff for optimal results. Other popular ones are the Cormier score, which is actually a more simplified version, and we use it in combination with fluoroscopy. And there have been some more recent ones where actually real-time 3D echo-based scores, where the individual segments are actually scored based on the thickness and mobility and calcification. So moving on to what are the indices, or we do use from echocardiography, basically our pressure gradients. Then you have the mitral valve area assessment from planimetry or based on the pressure half-time method or continuity equation. A little brief overview of a PISA method and what are the other few important indices of severity. Starting with our pressure gradients, we all know pressure gradients are the key to the assessment of mitral stenosis, right? Mainly the mean gradient. So gradients are usually obtained by averaging the mean instantaneous velocities, which is thankfully done by the computer for us these days. And it's actually backed by robust data from 1990s, where actually Doppler gradients were shown to be comparable to CAT-derived data, and even more recently have been validated to be even better. Limitations, again, we do have discrepancy between CAT versus pulmonary artery bed pressure. As you see here, it's mainly because of the phase shift in the pulmonary artery bed pressure measurement. And it's actually because of the delay in the transmission of the change in the pressure contour through the pulmonary circulation. Direct LAP is, of course, much more accurate. But again, remember, because wedge pressure, if you use it, could overestimate in cases with pulmonary venous hypertension. It also depends on the type of the catheter used, like balloon versus end-hole type, the accuracy of the wedging itself, and also the quality of the data. And again, in echo-derived Doppler gradients, the CW has made it even more feasible because measuring the peak velocity is much more easier, and angle issues are less of a concern because the beam could be placed straight across the mitral valve. But again, these gradients do have some pitfalls, right? So they're very dependent on flow rates and, with higher flow rates and higher heart rates causing higher gradients. And there is also this entity of low flow, low gradient mitral stenosis, which is less popular than our aortic counterpart. But there's one paper from Mayo actually showing that there is higher prevalence of AFib and diastolic stiffening in these cases, and is actually a topic of potential interest. Then comes basically, there is this interesting concept, which actually Dr. Little, has noted it. It is the concept of reverberation artifact or double envelope. And I think we've seen this quite often in our lab. This has actually been beautifully described by Dr. Rebecca Hahn in Twitter recently, that actually there was a paper which was showing it to be real because of hydraulic forces, but where she contradicted it by saying this is an artifact coming from a strong reverberation from the back wall of the left atrium. And she actually proved it by doing it on a normal case and increasing the gains and kind of reproducing the results. Bottom line is, when you see something like this, use the modal velocity or the denser flow profile and reduce the gains appropriately to capture the denser flow profile pattern. So moving on, conventional planimetry, again, if done accurately on decent quality 2D images, is actually a reasonably accurate, right? And color-coded real-time 3D is even more incremental in that. But of course, it's limited by image quality, and it's also very difficult. If the valve is really calcified and deformed, it's going to be very difficult to identify the tips. And it's again influenced by 2D gain settings. And remember, it should be measured right at the tip of the leaflets using the right tomographic plane. And as we all know, we classify less than 1.5 as severe, with a special mention to the term very severe mitral stenosis when the area is particularly less than 1 centimeter square. So the pressure half time, famous one, right? So it's defined actually as the time interval between the maximum mitral gradient in early diastole to the time point where the gradient is half the maximal initial value. It's again derived using the empirical Garland formula 220 divided by pressure half time, but its limitation should be kept in mind, especially in cases with E2A fusion or when there is discrepancy in LA or LV compliance, especially in cases right after valvuloplasty, and also in cases with severe AR, like and also when the velocity slope is actually nonlinear. So look at the gradient, the velocity slope of the gradient, right? So attention should be paid to the quality of the contour, particularly the deceleration slope. And sometimes you can also see these bimodal deceleration slopes, and then you don't really want to use the early part, but in these cases, you really want to use the mid-diastole than the early deceleration slope. As in the estimation of aortic valve area, the continuity equation is based on conservation of mass. As we all know, diastolic mitral flow is equal to aortic stroke volume, and it can be calculated by using the LVOT stroke volume divided by the VT of mitral signal. But again, it does have limitations, especially in cases with concomitant significant AR or MR. PISA method, I know we don't use this quite often in our lab, but it does exist, and it's a little more cumbersome because it does involve multiple measurements, and it is less validated, but can be rarely used in discrepant cases. Moving on to some associated lesions and some special situations. One scenario which is very important is the discrepancy between pressure half time versus continuity equation. Remember, we assume that the shape of the orifice is similar, but it's more tubular and calcific versus dome-shaped and rheumatic. And again, you want to integrate mitral valve assessment using continuity equation and other parameters. Let's look at one example. This is a case where you see a severely calcified mitral annulus with a measured pressure half time of 270 milliseconds with a gradient of 6 and a VT of 49. And if you pay attention, actually, if you use, in this case, there is impaired relaxation, which is causing prolonged, a pressure half time, resulting in a falsely lower valve area. And again, elevated LVEDP, on the other hand, basically can cause pressure half time to be low, causing overestimation of the valve area. The second scenario is, again, presence of significant MR or AR. And, again, we can't use continuity or pressure half time. And scenario 3 is the presence of irregular heart rhythm or AFib, where you want to at least use 5 cardiac cycles or use representative cycles, right? And the other parameters which are also helpful are PA systolic pressure, mitral valve resistance, and also in really discordant cases, exercise or dobutamine stress echo is very helpful. A quick look at the stages. We all know this, right? So valve area of less than 1 to 1.5 with a mean gradient of more than 10 and a PA systolic of more than 50 is categorized as severe. But again, remember stage C versus D in the valvular guidelines is based on the presence or absence of symptoms. Let's look at a quick case example, right? So a 58-year-old man actually who was completely asymptomatic in 2013, and as you see has a completely normal appearing mitral valve with a valve area of 2.3 and a mean gradient of 2 at a heart rate of 72 comes in. The same patient comes back in 2015 and now has maybe minimal exertional symptoms, now has a valve gradient, a mean gradient of 7 at a heart rate of 80, and now has an approximate valve area of 1.1, suggesting maybe more moderate calcific mitral stenosis. Now, this patient comes back in 2016 with, again, borderline symptoms of dyspnea and decreased exercise tolerance. And now you're like, well, what do we do in this case, right? So then we did a stress echo in this patient with dobutamine, and you clearly see the valve gradients increased from 7 to 19 at a heart rate of 109, suggesting severe mitral stenosis. So remember, the point I want to make here is actually you can subject these patients to exercise, preferably in bike also, so that you can really obtain these sequential gradients. More than 15 with exertion or more than 18 with dobutamine is the cutoff we use. And also an elevated systolic PA pressure of more than 60 with exertion is a cutoff for severe mitral stenosis. So finally, coming to the multimodality assessment of mitral stenosis, consider TEE when TT is suboptimal or in cases where you want to detect LA appendage thrombus or a left atrial thrombus. And of course, conventional invasive hemodynamics, we don't really do them these days, but can be reserved for very rare cases of discrepant data or in cases if you need pulmonary vascular assistance. And the role of CT and CMR, I'm sure Dr. Nabi is going to give you a detailed tour of that. And again, don't really want to talk too much about management, but we all know to consider percutaneous balloon valvuloplasty in favorable anatomy in rheumatic mitral stenosis versus MVR. The management of calcific MS is often challenging, mainly because of the decalcification maneuvers are very difficult. And some potential promising options include transcatheter mitral valve replacement in MAC, using balloon expandable or self-expandable valves, or there are also LA to LV conduits, which have been more recently used, like it's almost like a mitral valve bypass. Switching gears to the aortic valve, let's talk briefly about the anatomy again, some causes, and what are the main indices of severity and management. And actually, this is a recent pic of the Terminator himself getting an AVR, and I think that's Dr. Kleiman. Well, one quick question for the audience, if you're all still listening, what is this syndrome? Any guesses? Any takers? Fellows? Well, this is basically our Hyde syndrome, right? It's aortic stenosis associated with intestinal angiodysplasia and acquired von Willebrand syndrome. So a quick recap of the aortic valve anatomy. So aortic valve has 3 cusps named after the coronary artery origin, the right, left, and the non-coronary cusps. And again, the variants include unicuspid, bicuspid, and quadricuspid valves. And each cuspal edge actually has a central area of fibrous thickening called the nodules of Arantii, which actually recently have been shown to cause severe AR if hypertrophied. And also, one word about aortic valve cardae, and I know some of us are fans, including Carlos, who actually showed me this in a couple of cases. Actually, these are embryonic remnants and are in fact increasingly recognized to cause severe AR when they are thickened and they result in tenting of the valve and result in malcoaptation. Again, we all know aortic stenosis is not a benign disease. This paper by Ross and Braunwald, a classic one from 1968, was actually the first ever one to show in symptomatic aortic stenosis how average survival is 5 years after the onset of angina, 3 years after syncope, and 2 years after heart failure. And even in 2020, remember, symptoms are the key element in decision making. And remember, aortic stenosis is not simply a mechanical problem limited to the leaflets. It affects the upstream left ventricle and the downstream systemic vasculature. And there is robust evidence that aortic valve replacement prolongs life in patients with symptomatic aortic stenosis, regardless of the type or severity of symptoms or the response to medical therapy. So a brief outline again. I know we are trying to cover a lot, but mainly covering valve anatomy. looking at LV function and other associated abnormalities, a little bit about echo characteristics and alternative measures and basic grading criteria, and a quick rundown of special considerations or situations. So starting with our valve anatomy and associated abnormalities, let's start with talking about the classic paper by none other than Dr. Zogby and Dr. Quinones, who demonstrated the key concept of continuity equation based on principle of conservation of mass. As we all know, how it is dependent on accurate measurement of LVOT and also the spectral Doppler data, right? Both across the LVOT and the aortic valve. So very important point, right? How do you really measure LVOT? We know we use the zoomed parasternal long axis view in mid-systole, and it's measured inner edge to inner edge within 0.5 to 1 centimeter of the valve orifice. And this is very important, right? Because the error could be squared. And the next one, right? What else is important? The LVOT spectral Doppler data. Very important in apical 3 or 5 chamber or views with actually a 3 to 5 mm sample just placed proximal to the flow acceleration in the LVOT. And you really want to pay close attention to tracing the modal velocity, which is basically the brightest signal. And anatomic evaluation of the aortic valve is also important, right? It's based on short and long axis images to identify the number of leaflets and also look at the mobility, thickness, and calcification. Direct planimetry of the valve is okay. It's an acceptable alternative. But again, remember, a significant valve calcification can cause shadowing or reverberation, limiting the identification of the orifice. And caution, and also remember, anatomic orifice area is slightly bigger than the effective orifice area, which is more important. And coming to the other abnormalities, one important variant we always see is the bicuspid valve, which again is really fascinating because of its unique genetic and metabolic profile. And however, we don't want to go into the details, but we do know the most common variant is the fusion of the right and left cusp. And other ones are again, hypertrophic cardiomyopathy associated with aortic stenosis is one important one to know, where continuity equation could be challenging when there is proximal flow acceleration. And also, this is a case of subvalvular stenosis, where actually you can sometimes have a discrete subaortic membrane causing subvalvular stenosis. And the clue in this case being LVOT velocities and gradients being high with a typically normal-looking aortic valve. Moving on to our basic, echocardiographic measures and basic grading of severity. Jet characteristics. Very important, right? So these are the most vital components, particularly the peak velocity and mean gradients obtained using multiple acoustic windows, ensuring accurate alignment of the ultrasound beam. Again, remember, the peak gradient is obtained using the simplified Bernoulli equation with the caveat of using the complete equation when the proximal velocity is actually more than 1.5 meter per second, or if the aortic velocity is less than 3 meter per second. Mean gradient, again, is thankfully derived from, it's not the, 4 times mean, right? It's basically derived from averaging the instantaneous gradients over the ejection period, which again, thankfully, is done by the computer for us. And ode to Dr. Liv Hatley, who, as Dr. Zogby mentioned, is the mother of Doppler findings in aortic stenosis. The classic picture showing how, with increasing severity of aortic stenosis, the shape of the jet changes, right? In milder cases, you have the triangular early peaking jet to a more parabolic shape with a longer ejection time and a late peaking jet. That is the clue, right? And then this is a table, I think it's imbibed into our neurons of everyone watching this video. I'm sure you know this, in a heartbeat. And the criteria is, again, a peak velocity of more than 4 and a mean gradient of more than 40 for severe aortic stenosis. And a calculated valve area of less than 1 is typically severe, with few exceptions, which we're going to talk about in a little bit. And again, one word about the dimensionless index, right? A parameter which is actually normalized by body size. It's actually very helpful. If the value is less than 0.25, it suggests severe aortic stenosis. And again, remember, these are in normal high flow conditions where you have a stroke volume index of more than 35 ml per meter squared. A quick recap of the ACC-HA valve guidelines. What are the cardinal symptoms, right? You have dyspnea, angina, fatigue, heart failure, and syncope, right? A is at risk, and B is basically with progressive symptoms, and C and D being basically classified as being with and without symptoms. And AVR is again a class 1 recommendation, both for stage D1, C2, and for C or D, basically who do have, who are getting any other cardiac surgeries. So a quick word about special considerations, very important, right? When there is a discrepancy between the gradients and the valve area, first thing we need to do is to make sure our data is correct, right? First, you want to look for errors in calculation, errors in methodology, and also, ensuring everything is correct. Like we know we have got the maximum velocity and all that. And the second situation is where the flow, looking at the flow conditions, right? So in this case, the valve area could be more than 1 with a peak velocity more than 5, actually, in high flow states. And attention should also be paid to see if these high flow states are reversible or not. The second one, again, is the classic low flow, low gradient, severe aortic stenosis, where the EF is less than 50%. And the next one is basically the paradoxical low flow, low gradient, severe AS, where the stroke volume index is less than 35, but the EF is actually preserved. It's either equal to or more than 50%. So again, we don't want to go into the details, but one thing I do want to make sure is, remember if the LVOT is really calcified, it's very difficult to measure it accurately. And, it can really influence the assessment of aortic valve area. The second one is, again, check the LVOT flow signal for flow acceleration and making sure we are really measuring the modal velocity or the highest velocity. And one thing we also want to make sure is actually using multiple acoustic windows and also the PDOF probe. And again, when you're doing serial echoes, it's always important to also document which kind of window did we, capture the highest velocity so that we keep it more consistent. And a brief statement about low flow, low gradient AS. And again, we all know we do a dobutamine stress echo in these patients, starting with a dose of 2.5 to 5, achieving going up to a 20, ensuring maximum inotropic response. And you do it until you get a positive result. What can happen with DSC, right? So first is an increase in effective aortic valve area to a final valve area of more than 1. That suggests it is definitely not severe. The second scenario is where your more than 20% increase in stroke volume happens. That means if there is contractile reserve. And severe AS is an increase in the peak velocity of more than 4 or a mean gradient of more than 30 to 40, provided the valve area doesn't increase more than 1, right, at any flow rate. And the last one, again, one word is absence of contractile reserve, which means basically the LV didn't do anything, or the stroke volume didn't go up by 20%. It's actually a predictor of high surgical mortality and poor long-term outcome. Although valve replacement can improve function and outcome in this subgroup too. So let's look at one quick case example. So we have an 87-year-old with multiple comorbidities, as you see here, comes in with a valve looking like this, right? So you see the EF is around 30 to 34. And if you look at the valve parameters, you have a peak velocity of 2.7, a mean gradient of 30, and a valve area of 0.7. So what happens when we give dobutamine to this patient, right? So if you see EF did marginally improve a little bit. Now let's look at what happened to the valve parameters, right? So the LVOT VTI has now increased from 16 to 23, and the stroke volume has increased from 45 to 66, which is a 30% increase. Bottom line is the peak velocity actually did go up to 4 with the valve area of 0.8. And this is definitely consistent with low flow, low gradient, severe AS. What about scenario 2? So in this case, say if the LVOT VTI has increased from 12 to 20, but however, look at this, the peak velocity is still 3, and the aortic valve area has actually now increased to 1.4, suggesting that this is pseudo-severe AS. So what about switching gears to paradoxical low flow, low gradient, right? So in normal EF, it's more of a conundrum. So, and I think Dr. Zagbi has described this amazingly last time. So low flow is low flow, right? Be it a good ventricle or a bad ventricle. Remember to look for all these factors. We know those smaller, thicker ventricles in older patients being most common, of these, but also remember in patients, with severe MR, where the flow is actually going in the wrong direction, right? And bottom line is make sure you look at all these parameters and make sense that all the measurements are correct. And I think one good read on this is the editorial by Dr. Zagbi in 2015. So one example, again, so this is a 90-year-old. We have a smaller hypertrophied ventricle, and you have a peak velocity of 3.5. And again, you do want to confirm your measurements are correct in these cases, and also ensuring the stroke volume assessment is also correct. So finally, moving on to integration. So I know this is a flow sheet from our guidelines. I think is very helpful. Look at the high gradient versus low gradient. And, especially when you're looking at high flow, define the high flow and make sure there's reversible causes are excluded. And when you do have a low flow gradient and you are ensuring that everything is correct, you basically define them into, low flow, low gradient severe AS or paradoxical ones. And this is, again, a very interesting algorithm. One thing I didn't mention is always make sure whenever you're doing these measurements, the patient's blood pressure is controlled. So you're eliminating the role of higher afterload. And the next one is also the presence of symptoms. And the degree of valve calcification actually assessed by non-contrast CT may be the final important hint in this situation to really identify the true severe AS, right? We often approach our CT colleagues to do this. And so finally, a quick summary. So always echo first. Echo Doppler remains the first-line modality for assessment of aortic and mitral stenosis. Attention to details, very crucial for accurate assessment. And finally, remember integration of findings, right? Everything, put all the imaging findings together and put them in the right clinical context. That is the key. So thank you so much for all your attention. Sorry, I had to cover a lot, so I'm sure I was a little fast. And please reserve your questions to the end. Remember, live audience, please feel free to text us on Poll Everywhere with any questions as Dr. Nabi is preparing to take us through the world of CT and CMR and valvular stenosis assessment. Thank you again, and over to Dr. Nabi.
All right. Thank you, everyone. Thank you, Bindu. I will get going. We have a lot to cover here as well. So as Bindu very nicely showed, I mean, there is no doubt when it comes to the first test, echocardiography is the standard of care for both the initial assessment and longitudinal evaluation for valvular heart disease. And we heard really a lot of reasons why. You get information about ejection fraction, chamber size, wall thickness, morphology of the valve, severity of lesions. But there are situations where echo can have limitations. Image quality can be challenging. You may have difficult determining the aortic valve morphology. You may be in situations where you really need an accurate LVOT diameter. You may not have actually aligned with the Doppler flow jet in order to determine mean and peak gradients. You may not completely be able to visualize the aorta, and most importantly, you may have discrepant results between what you're interpreting and what the patient is telling you. And so for all of these reasons, CMR has strengths which can definitely complement echocardiography. And here we've talked about these in previous conferences, and I won't spend too much time, but as you well know, this is a technique with very high spatial and temporal resolution, really very good image quality, free choice of imaging planes, and I will show you how it is really gold standard when it comes to volumes and function, tissue characterization, and can provide us with accurate velocity and flow information. Now, with CMR, at least when it comes to aortic stenosis assessment, I'll spend most of my time discussing aortic stenosis because of the wealth of information with CMR and less so with mitral stenosis. But when it comes to aortic stenosis, there's some key questions we want to know, and CMR is very well poised to help answer those questions. It can give us information about LV morphology and function. It can tell us about aortic morphology and valve area. It can help with aortic valve velocity and flow. We can definitely characterize the myocardium very well. And in patients such as those with bicuspid aortic valves, it's a very powerful technique to be able to look at the aorta. And with CMR, as I'm demonstrated in this slide, we use a variety of different sequences which I'll introduce you to as we go along in this talk. Now, here's a clinical case I want you to remember as we go through my slides. This was a 58-year-old physician with a history of hypertension, dyslipidemia, presenting with increasing shortness of breath. Physical exam is suggestive of severe aortic stenosis. The echo demonstrates a normal ejection fraction, a very heavily calcified aortic valve. However, the peak gradient is 3.2 meters per second across the aortic valve. The velocity was obtained from different areas. However, the jet always seemed to be incomplete in profile. And finally, the aortic root also appeared to be enlarged, as well as the ascending aorta. So this would be a good reason to consider CMR. Here we have a discrepancy between what the physician feels on physical exam and the quality, the echo that was obtained. So how can CMR help us with aortic stenosis? So as I had alluded to before, the first thing is, can it tell us about the LV, about the morphology of the left ventricle? So here's our patient, and I'll be referring to this patient as we go along. And I hope you'll appreciate that the ventricular function looks normal. You can definitely see that the aortic valve has a minimal systolic opening. It's dark, telling us that it's heavily calcified. There's flow acceleration at the level of the aortic valve. And then the ventricle, if you look at the myocardium itself, appears thickened, and you may have already jumped to the conclusion that there is hypertrophy of the myocardium as well. And when we did our analysis, and I will show you how we actually do all of this, you can see here that the ventricle was normal size at 174 mils. Cardiac mass, LV mass was increased at 248 grams. Stroke volume and ejection fraction were both preserved. So this was a case where you had normal biventricular size and function and concentric LV hypertrophy present. Now, so how do you actually go about performing these volumetric analyses? I won't spend too much time. We've discussed this in prior conferences, but the basic idea is you create slices from the base of the heart all the way towards the apex. If you trace the cavity and you know your slice thickness, you can determine a volume for each slice. You'd add up all the volumes, and then diastole, add up all your volumes, and then systole, and you're able to determine your LV stroke volume as well as your ejection fraction. And the most important point I can relay here, really when it comes to volumes and function, CMR is the gold standard. And this can be very important, as you know, in patients who have asymptomatic severe aortic stenosis, when there is a question of ejection fraction, because as you know, if the EF is less than 50%, that is an indication for surgery. Similarly, just like we trace the subendocardium when we determine volumes of the cavity, if we trace the epicardium, the difference between the epicardial tracing and the subendocardial tracing is your myocardial mass volume. And then simply multiplying this by myocardial density, you're able to determine actual mass of the left ventricle. For these calculations, it's important to note that we do add the papillary muscle to the myocardial mass, and that all of this is free of any geometric assumptions. LV mass determination, as it turns out, is an extremely important variable, as in numerous echo and CMR studies has been shown to be an independent predictor of cardiovascular events. And I'll just one more time emphasize that when it comes to myocardial mass assessment, CMR is again the gold standard. CMR can also tell us a lot about how the ventricle remodels in the setting of an increased afterload with aortic stenosis. So this was a study of 91 patients, and you can see here that there's a variety of different morphological LV remodeling that can occur. Most patients in general will develop an increase in relative wall thickness or an increase in LV mass index. However, there are a few patients, about 12% in this study, which had completely normal morphology, and whereas there was another 10% who had eccentric hypertrophy and dilation of their ventricle. For future purpose of my slides, just pay attention here, 15% had asymmetric hypertrophy. And this is a very important finding, and I'll tell you for reasons coming up. And really, this was the study that showed us, the finding of asymmetric hypertrophy in the setting of aortic stenosis is not uncommon. In this particular study, 26% of patients had that, and what it was associated with was elevated biomarkers, both troponin and troponin, and when you follow these patients out in the long run, you can see those who have asymmetrical findings, wall thickness had worsening prognosis. So this definitely had this pattern of remodeling has prognostic significance. Another very important finding we can learn from the CMR literature is that men and women behave differently in how they remodel. And this is really a summary graph of what this paper found. What you will notice is in that men, in general, they increase their LV mass, and this is associated with LGE, an increase on T1 and ECV, whereas women, on the other hand, actually develop concentric remodeling and without the development of LGE. And they're symptomatic more often because of the development of elevated filling pressures. So it seems women and men behave differently in their phenotypic response to aortic stenosis. Let's move on to aortic morphology and the determination of an anatomical valve area with CMR. Here is a nice slide of different types of morphologies you can see with CMR. I think all of us would agree when it comes to determining the type of morphology you have, it can be very simple with CMR. Visualization is very good, and you're able to make out both the roots, the cusps, very clearly, as well as any calcium, which is usually the dark thickening that you see on the leaflets. Now, if we look at specifically our patient, this was our patient. What I've done here is using our long axis cuts, I've created a stack of short axis cuts of the aortic valve, going from inferiorly all the way superiorly through the aortic root. And I think if this was our particular patient, I hope you'll agree with me that this is clearly a Sievert type 1 bicuspid aortic valve with a raphe between the right and non-coronary cusps. Now, how do we actually go about determining a valve area? Well, the important point to mention here with CMR is we use planimetry, which is different from the effective orifice area, which is obtained by the continuity equation with transthoracic echo. So here we will actually planimeter each of these different slices that I obtain through the aortic root of the aortic valve in short axis. And really here I've done that, and really the planimetered valve area is by definition the smallest maximal systolic opening at the leaflet tips. And you'll see here that we're very careful to trace the inner valve leaflet edges, and in our patient, we determined a valve area of 0.9 centimeters squared. So what does this mean? So this was a large meta-analysis that was recently published, showing us that if you compared planimetry by CMR with planimetry obtained by transesophageal TE, you will notice that there's very little difference between the two measurements. So really where a CMR is very well able to duplicate non-invasively what you're able to planimeter with TEE. Similarly, if you look at this study, which took 48 patients, and all these patients underwent echo, CT, and MRI, you notice very nicely here that the correlation with MRI and CT was really the strongest. So when it comes to planimetry by CMR is a very robust technique compared to the other techniques. What about the planimetered aortic orifice area, anatomical orifice area? Well, this is a study that looked at a meta-analysis that looked at many different studies, and what you can consistently see is that, and a real teaching point here is the measurement that we determine by planimetry is larger than the physiological valve area. And in general, this is on the range of about 10%, or if you want specific numbers, 0.1 plus minus 0.17 centimeters squared. So, in general, what we planimeter tends to be just slightly larger than what is obtained by the continuity equation. So, now, another very important point to note is that there are no clinical outcome studies based on planimetered valve areas. So we really don't have a validated prognostic threshold. But however, since we tend to overestimate the effective orifice area by roughly 0.1 to 0.2 centimeters squared, you can be confident that if you planimeter a valve area less than 1 centimeter squared, that this is a very strong argument in favor of severe aortic stenosis. There have been efforts done by the community to be able to calculate a physiological valve area. This is a study that used a semi-quantitative software, and they were able to replicate with a very high R values that were obtained by echocardiography. Let's move on to another very important component in the assessment of aortic stenosis, and that is of the peak antegrade velocity. For this, we use a sequence called phase contrast CMR. We use in-plane phase contrast CMR to actually visualize the flow, which is on the left side of your screen. Here we can see a narrow velocity jet in the aorta. This is your aortic stenosis profile jet. And what we're basically going to do is we're going to create, using our log axis views, we're going to create a through plane image at the point of maximal velocity. And that's done. And then once we've created that through plane image, that is the image that we use to quantitate velocity and flow. So how do we actually go about figuring out the severity of the velocity across a person's aortic valve? This is really done doing what you're seeing here. Similar to echo, this is a velocity map, and we actually have to input in what we call the VENC, or we have to actually input the maximal velocity that the computer will see. And any velocity higher, you will get aliasing in the imaging, and aliasing is simply where you have both a white and black color scheme in the image. And you can see here we have a lot of aliasing at 3.75 meters per second. We redo the sequence at a higher VENC at a velocity of 4 meters per second. You still see aliasing. Finally, when you get to 4.25 meters per second, you can see the aliasing is now gone, and you have a nice, smooth color profile. And that would be the maximal peak aortic velocity in this patient's case. So it's really the lowest velocity where there is no aliasing. There is software where we can try to determine the velocity in greater accuracy, and we can actually trace a region of interest and determine peak velocities. Now, this technique, of course, with CMR and peak velocities has been, of course, validated against transthoracic echocardiography and has shown good correlation. However, it is important to note that in general, with CMR, we tend to underestimate velocities, and there are a couple of key reasons why. Number one, you have to make sure that we have perpendicular flow With CMR, we have to be perpendicular, whereas with echo, as you know, you have to be parallel to flow. Second is we have a certain size thickness to these sequences, and you can have partial voluming of the velocities. And then finally, we may also have lower temporal resolution, which can also cause us to underestimate the peak velocities. But again, an important point, as I did for the valve area, that if by CMR you do determine the peak jet velocity to be greater than 4 meters per second, again, this is a very strong argument in favor of severe aortic stenosis. All right, now really the bulk of interest with CMR really comes to tissue characterization, which is its primary strength, and we'll be talking a lot about myocardial fibrosis. Now, we've known for a long time, this was a study of patients who were going to the operating room for aortic stenosis, who had a biopsy performed, that the more fibrosis that was seen, the worse outcome these patients had. Well, isn't it great that we have a technique that can readily, non-invasively identify fibrosis? As you know, we have two types of fibrosis. We have replacement fibrosis, and this is what we call focal replacement. This tends to occur late in the disease process and is an irreversible process, and this is determined by late gadolinium enhancement, or LGE. The other type of fibrosis that CMR can assess is called interstitial fibrosis. And interstitial fibrosis tends to occur early. It tends to occur diffusely through the ventricle and is a reversible process. This is assessed by both T1 and ECV, or extracellular volume fraction. So let's talk a little bit about LGE. So these are some typical types of LGE patterns that are seen in patients with aortic stenosis. You can have a normal profile. You can see a patient in B who has a subendocardial infarct, or what you can see in C, D, E, and F, where you have this mid-wall patchy fibrosis. This is like most common finding that we can often see in patients with aortic stenosis. Let's take a look at our patient. This is our patient's LGE images. And I hope you can appreciate in the basal and mid slices, you see this patchy mid-wall fibrosis really throughout the ventricle. And this was quantitated to be approximately 12% of the ventricle. Now, what does this mean? Large studies have clearly shown that any type of scarring in the ventricle, whether it be a non-infarct pattern or an infarct LGE, is bad news and is associated with almost a twofold increase in mortality. So just the fact that this ventricle had injured itself is a bad prognostic finding compared to the patient who had no LGE. If you take a look at those patients with LGE and compare it to the counterparts who had no evidence of LGE, you can see in this study that 51% of patients had evidence of scarring, and those patients with scarring in general were male, were known to have larger ventricles with a higher indexed LV-EDV, higher indexed LV mass, and a lower ejection fraction. So these were really ventricles that had decompensated and were injured, and that's really what the LGE was providing useful information on. So another very important teaching point, that CMR detects ventricular decompensation in aortic stenosis through replacement fibrosis. So if you see evidence of scarring, it's already a sign that the ventricle is failing. Another scarring pattern that you have to be aware of that I will make mention of is this diffuse subendocardial to transmural LGE pattern. Studies have shown, especially those with severe AS who are undergoing TAVR, who are then screened prospectively with technetium PYP scans. 16% of these patients were positive on their PYP scans, suggesting they had ATTR cardiac amyloid. So another pattern that you may very well see that this patient demographics shares both these diseases. And the other common phenotype that you'll often see this in is the low flow, low gradient phenotype. So a lot of these patients who are getting TAVRs have this low flow, low gradient. These are the phenotypes that in general had the cardiac amyloid pattern. Let's move on to interstitial fibrosis also, which can be determined non-invasively with CMR. As you know, this is done by measuring T1 times in the blood pool and the myocardium, both before and after give the administration of contrast, and you also have to know your hematocrit. This was my calculation on my patient, the same patient that I had shown you. You can see how easy it is. You really just need a tracing in the blood pool and a tracing of the myocardium, and I was able to get an elevated ECV of 29%. What does this mean? There have been now large studies showing that as your severity of your ECV increases, that means more your interstitial fibrosis increases, your risk of adverse events, and here all-cause mortality was significant, goes up. So again, a very pathological finding that if you have the development of any type of fibrosis, be it replacement or interstitial, this is bad news for this patient and the ventricle. These patients who had elevated ECVs, you can see here very nicely, it correlated with increased LV mass, increased left atrial volumes, greater degrees of New York Heart Association class heart failure, increased likelihood of having LGE present, and lower ejection fractions. So the next point is CMR detects ventricular decompensation in AS both through replacement fibrosis and extracellular expansion. So very, very important. And this was just a nice study. You can imagine that you may have patient populations with aortic stenosis who have normal myocardium, both by ECV and LGE, or you may have just expansion of the extracellular space with an increased ECV without an LGE, or you may have a patient who has replacement fibrosis. And this study very nicely showed us that as those patients who have replacement fibrosis do much worse prognostically than those who simply have expansion of their extracellular space compared to those patients who are normal. So really what we're now understanding about aortic stenosis is that this is a disease where once the afterload increases, the heart remodels by increasing wall thickness in order to decrease wall stress. However, this at some point becomes a pathological process. There's supply and demand ischemia that can set in, mechanical stress, myocyte proliferation, and you eventually have interstitial fibrosis happening. Eventually cell death occurs and you have the development of replacement fibrosis. And finally, the next stage is a weak failing heart. There are studies now that are in progress that are using CMR to try to identify patients earlier before the ventricle fails. And basically these would be patients here who would asymptomatic severe AS, who would be screened with CMR, and if they had any evidence of LGE, they would undergo early intervention, and we'd look forward to the results of this trial. CMR has also been looked at reverse remodeling, and here were patients who had a CMR at baseline and then underwent AVR, and basically this graph, this beautiful figure kind of summarizes this paper, which shows you that after AVR, at least at post 1 year, ECV actually went up. And the reason it goes up is actually you have more myocardial muscle regression than you have regression of the interstitial matrix. So temporarily, a muscle tends to remodel faster than the interstitial. And this is what we kind of learned from this, is that you can see here as aortic stenosis progresses, you have the development of increased mass, replacement fibrosis, and diffuse fibrosis. Once AVR occurs, the replacement fibrosis never goes away. Both the mass and the diffuse fibrosis will decrease, but the mass will decrease faster. All right, and then of course CMR can be a very powerful technique. When we look at stages of aortic stenosis that has been proposed, we can really look for, beyond LV damage, we can look at left atrial and mitral damage, pulmonary vasculature and tricuspid damage, RV damage, and as you know, as you progress through these stages with aortic stenosis, your prognosis progressively worsens. Just reminding us that AS is a global disease. All right, finally, of course, the aorta, we can make complete measurements of the aorta. Here, just in this same patient of ours, I'm measuring the aortic root, and you can see it measures 4.4 at the mid-sinus level. We can also perform 3D ECG-gated MRAs, and this example here. Again, note this is completely without iodine or radiation. It's important in patients with bicuspid valves to assess the aorta in order to rule out aortopathies and coarctation. Here I'm measuring the ascending aorta of my patient. You can see here, this is important for this patient. His ascending aorta was 5.1 centimeters. As you know, the guidelines have given it a 2A recommendation in those patients who are going on for surgery, that if their bicuspid valves, if the aorta is greater than 4.5, that is an indication for surgery. There's a lot coming out that will be coming out on 4D flow, and this is just a flavor of some things to look forward to, and I won't spend too much time on this. And so just a summary of our case, our patient went on to have a successful bioprosthetic AVR and ascending aortic repair. So these are some other clinical situations where CMR will be very useful. I think, of course, pre-TAVR, we can do this all completely without iodine in those patients who have nephropathy. We discussed bicuspid AS. Those patients who have combined AS, AI, mixed valve disease, it can be very difficult with eccentric jets due to calcification. With echo, we can quantify AI very easily. Low flow, low gradient, it's important to know why. We can definitely determine viability, and we can also identify whether the patient has cardiac amyloid, and so very helpful technique there. Asymptomatic AS, if you're unsure of the ejection fraction, CMR can be very helpful. We can also do strain imaging, which has shown to have prognostic value. And CMR can also be very helpful in those patients who have concomitant subaortic obstruction with AS. I won't spend too much time on mitral stenosis because you can see how dependent it is on heart rate and gradients. But similar to what we do in echo, we use our long axis slices to create short axis views of the mitral valve. We can polarimeter this, and polarimetry again has correlated nicely both with transthoracic echo and TEE. So I'll just summarize by leaving this on the screen. Echo is really the cornerstone of AS evaluation. CMR is a very good non-invasive alternative compared to invasive coronary angiography and TEE when echo results are equivocal. Myocardial fibrosis, both replacement and diffuse, is a marker of LV decompensation. And CMR strength is identifying adverse myocardial responses, both morphological alterations and fibrosis to AS. And finally, it permits the complete evaluation of the aorta. All right, I'm sorry we went over a little bit, a lot of information from both our sides. We look forward to any questions, either from the online audience on Zoom or for our friends who are joining us on Facebook, Livestream, YouTube, and the other channels. If we don't have any questions, it was a pleasure this afternoon, and we look forward to seeing you next Tuesday.
Thank you for joining us. Thank you.